And as most of you all know, Puerto Rico in 2017 was slam danced with 2 hurricanes. On August the 21st, Irma took a shot at us, crossed over the northern side of the island, maybe 100 miles off the coast. Wasn't a direct hit, but we had a lot of wind, a lot of rain, took out the power grid to a great extent, what have you. On September the 20th, however, we weren't so lucky. Hurricane Maria did a dead landfall. And I think at the time she made landfall, she was at a Category 4 level. Although before she hit us, it was at a Category 5, which basically meant we were the people who were the bioterrorism group doing community disaster planning. And when Irma hit, particularly after Maria hit, I was sitting in my office just sort of devastated by what had happened to us. See if I can move this a little bit. And had really just finished a phone conversation with a dear friend who had just finished telling me about how she alone had lost 5 close friends. Not because they got killed during the hurricane, but because they died because either they didn't have their medications and were isolated in the aftermath of the hurricane, that they were found too late, they had chronic conditions, severe conditions, were airlifted to the mainland for treatment, but either died en route or soon thereafter because they had been without the treatment for a long time. And that was one individual who had lost 5 people. And this friend is in the same age cohort that I am in. So this slide basically says, you know, the official death toll within Puerto Rico, the Commonwealth, last count was estimated at 64. The Harvard University released a study the last couple of weeks that estimated the death toll at being around 6,400 people. That's been debated. But the reality is we really don't know how many people died, either directly during the hurricane, but mostly in the aftermath because they were isolated, didn't have access to medication, didn't have access to ongoing support like oxygen, things of this nature, many, many different complications. And as I sat there looking at what we had done with ITV2 and everything that my friend and I talked about and reflecting on my past life in emergency planning, again, in a conversation with Mike, who we'd been working with for a while, I said, isn't there something we can do with I2B2 in a preparatory mode? We're doing wonderful things with it in terms of science looking forward. How can we use this tool to really reach out and help prepare in the case of natural disaster? So he and I, and basically Mike, when I asked him the question, he went, well, let me think about it. And about an hour later, he said, yeah, we can do this. So we have put together a prototype called Invcheck, which is Identify Natural Disaster Vulnerabilities Checklist. And the idea is that with Invcheck, we were looking at ways that we could use the tool I2B2 as a resource in innovative ways that helped us look at the available big data that we had coming from our EHR ETL system, so that everything that we needed to make this product operational was already in our clinical data repository. Leveraging the anatomy of I2B2 and the fact that it's an open source software, it is structured on ontologies that are sound, well developed, you know, accepted, the whole bit, so that as we again have look at our different hospitals that have input into our I2B2 system, those ontologies enable us to have a uniform way of searching the data. And again, it's to leverage what we had available in terms of other open source software that Mike could use to bring in different features that were essential for healthcare emergency personnel and first responders to use this system in the field as we had intended it to. So the goals that we had were to look at the architecture map of the Invcheck application, in that we were going to bring in data from the I2B2 system, again leveraging open source software tools. I2B2 has the ETL process. We're going to leverage that as part of Invcheck. And also within this, to be able to create a computer interface and an application portal. And that application portal, we, again, constructed it with the idea that it would be used by hospital emergency personnel and first responders in the field.
Thanks, Mary. So, so the architecture around it, as you can see, is going to have everything. Most of the system is going to be in your HIPAA compliant. So, utilizing outside resources, it's mainly everything is internal. So, the Invcheck application server. Right there. So, this is the main application server. This is a web-based application. It's going to connect up to multiple different databases. One is going to be the OpenStreet server. So this is similar to the street maps that you have with Google, but OpenStreets is a publicly available one. And we can actually host the whole application internally, so we're not releasing any type of addresses to Google, which would be a violation of any type of HIPAA. So everything, like I said, is going to stay internal. The Open EMPI is an enterprise management. The Open EMPI is what it stands for, Enterprise Master Patient Index, and that is what's going to have the connection to the patients, the full names, the addresses, cell numbers, and that information is loaded from the data warehouse. And so the Invcheck data warehouse and ETL is the system that would extract the data from the EHR systems and get it ready for the Invcheck system. So to give an idea of the portal, so you would begin by creating a patient cohort. And so in that patient cohort, you first begin with any type of demographic information you want. For example, maybe you want to just do anyone who has chronic kidney disease that speaks Spanish, so that you can deal with, and then the first responders who are familiar with Spanish would deal with that cohort of groups. So you can also specify a date range within that. The next part of the wizard is selecting the ICD-9 CPT code for the procedures or diagnosis that you're interested in. And then the final one is any type of, say, medications. So the medications, if there was a complete power outage and the refrigerators are down, and then the medication the patient were taking needed to be in the refrigerator, then you could do a query based on medications that are at that type of risk. So once you've created the patient cohort, the next screen is looking at the patient cohorts, and we have a demo which you can demo this. But basically, what it is these are a list of the patients. I also want to note that this is not real patient data. This is all fake data. So it gives you a screen of all the locations of all the patients, and it color coordinates it based on the machine learning to try to coordinate groups of first responders with locations of the responders. And so then there's also a breakdown of the different groups that it had done. This is the mobile app, which would demonstrate how the first responder or the driver, whoever is either delivering the medicine or responding to something would see. So as we mentioned, we're extending the ETL system. So in order for us to make it so that it would be easy for people to load their data into the Invcheck machine, we broke down the ETL into 4 sections. One was the loading zone. And in the loading zone, it would be basically a one-to-one relation to your current EHR system. So if you had a patient's table which had F name and then L name, we'd have the exact same table in our system, patient with L name and F name. So it's a complete one-to-one relation. And then also in the loading zone, we then would, so the only work that you have to do is map these tables to a standardized table structure. Once that standardized table structure has been mapped, you just run through the rest of the zones, because the rest of the zones are going to be based on that standardized format. So for example, if in our standardized zone we said patient first name and then patient last name, all you'd have to do is map your F name to full name, first name, and then L name to last name. So that would be the loading zone. The working zone is it's an optional zone. So what this would be is if your IRB requires that you have everything de-identified and no relation back, this is where the working zone would then strip the MRN, create a patient mapping table, put in an identifier for that patient to that real MRN, and then load that data into like the identity management cell, which would then the Invcheck would then use that to extract the PHI information which would be needed. The next zone is the data zone. This would be taking the data from the working zone and then actually loading it into the star schemas. And then the very last one is the ontology zone. And so depending on the standard, which ontologies you are interested in, you would have the mapping of the ontologies and any type of other mappings that are not done. But typically, they would just be the standard ICD-9 or CPT or SNOMED ontologies. And so this is just a quick UI of the possible loading the ontologies. And this is actually Microsoft SSIS, which I've used a lot. It's very robust in loading massive amounts of data.
And again, this just looks at the some part of the architecture, looking at the ontologies, ICD codes, and the LOINC codes are all in multiple languages. So this gives, in terms of the role in Puerto Rico, what we're finding is that all of the information that is loaded into the EHR systems are in English. But because it's in multiple languages, this application could potentially be, put into any geographical area. The first one that you have shows the interface in Spanish, then in Japanese, and then you have it in French. So it can be implemented, it's transportable across languages. Where we go from here? Again, for Puerto Rico, this particular type of an application has potential because our emergency management system has nothing. And when I say nothing, I mean when Maria hit, again, with my background in emergency preparedness, it's like I felt like they got to the 10-yard line and then everybody just sort of lost their mind. When I went back and asked people in the Department of Health and emergency departments, they universally kind of said, well, yeah, we have plans, but the level of the disaster was so much that everybody became overwhelmed and just sort of threw away the plan. They just said, well, okay, we're going to wing it. And I just kind of went, no, but that's what they did. But from the hospital perspective and talking to our emergency department directors, they in particular have a great level of concern, particularly for those patients that they know are frequent users of their facilities with chronic diseases that represent high utilization, high cost to the hospitals, and the ability to have been able to identify them in a very specific manner, to have been able to deploy teams to go check on people to make sure they would be able to shelter in place safely, have the necessary medications on hand to last for a week, 2 weeks, 3 weeks, oxygen, be able to make plans to extract those who are not going to likely be able to handle any level of separation, would have, we believe, helped reduce the number of deaths in the island, or at least hopefully not have contributed to worsening the clinical cases of many people. NIH did release a FOA in April. It was a rapid turnaround, looking at, it was a time-sensitive research in health risk and resilience after hurricanes Irma and Maria. Looking at study concepts for Puerto Rico and the US Virgin Islands. We submitted to that. We, along with, I think, maybe around 700 other applicants, we were not scored. They have not yet made the announcement as far as they know on that. But we have a lot of support from our emergency department folks. And so right now we've gotten feedback from the program officer at NIH with 2 additional funding opportunities that we're going to pursue with this. We're also working to get before the director of our emergency management department, as well as our Department of Health secretary. We had letters of support from those folks when we submitted the application, but we're wanting to get FaceTime with them to actually, now that we have a demonstrable model, to see if we can get a nickel out of the 10 cents that they have. And that's not an exaggeration in Puerto Rico. And we're also developing a white paper that we'll be sharing with different organizations and entities. Right now we've gotten leads from the Department of Defense, and we're trying to find a contact within FEMA to see if maybe there's someone within that organization that will listen to us. So, and if anybody has any ideas of potential funding opportunities, please let us know. So again, this is really, we were looking at a way to use I2V2 really in a very different way than what we've talked about all day long. This was looking at it as a way for community response and for healthcare preparedness. And I'm going to turn it back to Mike for a demonstration.
Thanks. Okay, so we're going to log in. Admin. Okay, so as an administrator, you would see some type of statistical analysis about the system, how it's doing, queries that have run, queries that failed, any type of statistical analysis that was interesting. So we'll begin by creating a patient cohort. Name the query, so chronic kidney disease, and I'll call that KCD. Because we're in the patient population, we're going to query based on some type of population, so we can do like Asian if you want, or you could do males. For this, we're just going to leave it blank. We're just going to say any patient population. So the next is the diagnosis of procedures. So if you know that ICD-9 N18 is chronic kidney disease. We can select that, and so now we're interested in all the patients who have chronic kidney disease. And so this is the medications and labs that we could select, but in this case, we're just going to leave it with that chronic kidney disease. We're going to finish it, and we notice we get a query that resulted in 206 patients in less than 5 milliseconds. So after the query is done, it would be then placed in a patient cohort section. And so we select chronic kidney disease. And so this is using that OpenStreetMaps. And so as you can see, we would group patients based on locations. And so as you can see, there's like a main artery road here. So if there was a handful of patients on this on the seacoast that was outside of the main San Juan, then they would all be grouped in the same color coordination. Also on the legend, it represents who the drivers are or the first responders for this group of patients. So if we start to zoom in to the San Juan area, we notice that we would have cars that represent the drivers or the first responders, and you can click on it and then get the name of the person, and you can see exactly the location they're at. And so also, as you can see, if you type in notes, and that would be sent directly to the responder or the driver, and so that they can get updated information. And then it has full name, address, demographic information that you can send, and then the telephone numbers and some items. And so this is, like Mary said, this is our prototype demonstration. The only other thing I wanted to demonstrate was localization aspect. So now it's switched into the Spanish version. And so if we go back to just the patient cohort section, or if we do a new query to reload it, as you can tell, the whole system has been localized in Spanish. If we go to our next screen and we type in ICD-10 and 18, you can see that the whole ontology is also localized in that Spanish language. So it's not just the application, it's the complete ontology. And so that's what we wanted.
We have a question in terms of
What?
the telephone systems.
Right. So we had our first mission was so our first mission was to try to get funding, and then we did create this prototype. We actually have thought about how to deal with because Puerto Rico had a complete 100% power outage. It wasn't 99. There was no one who had power on the island. So as a result, the cell systems were completely down. So we actually decided to investigate using like shortwave radios and ham radios and other type of amateur radio technologies in order to do some type of response. It's changed in the last 20 years or 30 years that they have the packet radio, the TCP over ham. There's lots of ways that you can actually tether your laptop or your phone to a ham radio so that you actually do have full functionality you could see on the app because it's tethered to the packet over TCP so that you have full communication back.
If you know of any financial angels, I'm happy to give you my name and contact information and send them our way. All right, thank you.
Thank you.